This is Chapter 7 of Conquering Scoliosis Pain, Surgical Interventions. Surgical intervention for scoliosis-related pain is typically considered a last resort, reserved for cases where non-surgical treatments have failed and the patient's quality of life is significantly compromised. Surgery may be recommended when the spinal curvature is severe, often exceeding 45 to 50 degrees, continues to progress, or causes persistent disabling pain, nerve compression, or loss of function. Other indicators for surgical referral include spinal instability, respiratory compromise from thoracic curves, or worsening neurological symptoms such as numbness, weakness, or bladder dysfunction. The most common procedure, spinal fusion surgery, aims to stabilize the spine, correct deformity, and reduce pain by fusing affected vertebrae together using rods, screws, and bone grafts. While the goal of surgery is to provide long-term relief and prevent further curve progression, it carries significant risks, including infection, nerve injury, limited mobility, failed fusion, and the potential need for additional surgeries later in life. Recovery can be lengthy and demanding, involving physical therapy and a temporary reduction in activity. For many adults, surgery may not eliminate pain entirely, but rather aims to reduce its severity and prevent worsening. Therefore, surgical decisions should be made carefully, in consultation with a spine specialist, and only after exhausting conservative care options. Spinal fusion surgery. Spinal fusion surgery is often viewed as a last resort intervention for individuals with scoliosis who experience significant pain, functional limitations, or progressive spinal curvature that has not responded to conservative treatments. While originally developed to halt spinal curve progression in adolescence, spinal fusion is now also used in adults whose scoliosis causes chronic pain and reduced quality of life. Understanding the procedure, recovery process, potential benefits, and long-term risks is essential for patients and families considering this major surgical option. Procedure overview. Spinal fusion surgery involves permanently joining two or more vertebrae using bone grafts, rods, screws, and other hardware to stabilize the spine and reduce abnormal curvature. The goal is to eliminate motion at the affected segments of the spine, which can reduce pain associated with instability or mechanical stress. The operation is typically performed under general anesthesia and may take 4 to 8 hours, depending on the complexity of the curve and the number of vertebrae involved. In scoliosis cases, surgeons often approach the spine from the back, posterior spinal fusion, but anterior, front, or combined approaches may be used. The spine is straightened as much as safely possible, then fused in the corrected position. Over time, the bone grafts grow and solidify into a single bone mass, stabilizing the corrected spinal structure. Recovery and long-term outcomes. Recovery from spinal fusion can be lengthy and demanding. Most patients remain hospitalized for 3 to 7 days post-surgery. During this time, pain is managed with medications and physical therapy may begin gradually. Patients are typically advised to avoid bending, twisting, or lifting heavy objects for several months. Bone fusion may take 6 to 12 months, and full activity may not resume until 1 year post-op. While many patients experience significant pain relief and improved posture, outcomes vary. In younger patients, especially adolescents, spinal fusion tends to produce favorable long-term results. In adults, especially those with degenerative scoliosis, outcomes can be more variable due to age-related changes, coexisting health conditions, and the body's slower healing process. Considerations for chronic pain relief. Although spinal fusion may alleviate pain related to spinal instability, nerve compression, or progressive curvature, it is not guaranteed to eliminate all scoliosis-related discomfort. Chronic pain after surgery may persist due to factors such as pre-existing nerve damage, compensatory strain on adjacent spinal segments, muscle imbalances, underlying inflammatory conditions. It is essential for patients to set realistic expectations and understand that spinal fusion stabilizes the spine, but does not necessarily address all sources of chronic pain. Postoperative rehabilitation, muscle strengthening, and ongoing pain management may still be required to achieve optimal results. Risks and long-term complications. Spinal fusion surgery carries significant risks, especially in adults with complex scoliosis. These may include infection, blood clots or excessive bleeding, hardware failure or loosening, non-union, failure of the bones to fuse properly, nerve damage or spinal cord injury, persistent or new onset pain, loss of spinal flexibility and function. One of the most concerning long-term complications is adjacent segment disease, ASD, a condition where vertebrae above or below the fusion site degenerate faster due to increased mechanical stress. This can lead to new pain and the potential need for additional surgeries. Other possible long-term issues include implant wear, muscle atrophy due to decreased motion, and psychological effects such as depression or anxiety in cases where pain relief is incomplete or functional limitations persist. Nerve ablation and spinal cord stimulators. As the understanding of scoliosis-related chronic pain evolves, treatment options have expanded to include advanced interventional pain management techniques, particularly for individuals who are not candidates for surgery or have persistent pain despite previous interventions. Two of the most promising non-surgical strategies are nerve ablation and spinal cord stimulation, SCS. Both offer targeted relief for scoliosis patients struggling with debilitating pain, especially when that pain arises from nerve irritation, facet joint degeneration, or central nervous system hypersensitization. These approaches do not correct the spinal curve, but aim to disrupt or override pain signals, providing meaningful quality of life improvements for selected patients. Nerve ablation, also known as radiofrequency ablation, RFA, or medial branch neurotomy, is a minimally invasive outpatient procedure that uses heat generated by radio waves to temporarily disable specific pain-conducting nerves, typically the small medial branch nerves that supply the facet joints. In scoliosis, asymmetric spinal loading can accelerate facet joint degeneration, particularly on the concave side of the curve, leading to local inflammation, joint stiffness, and persistent axial back pain. RFA works by interrupting the pain signal from these inflamed joints before it can reach the brain. First, a diagnostic medial branch block is performed using a local anesthetic to confirm the origin of the pain. If the patient experiences significant short-term relief, they may be a candidate for RFA. During the ablation procedure, a thin needle is guided to the target nerves under fluoroscopic imaging, and the nerve tissue is thermally coagulated using controlled heat, typically around 80 degrees Celsius for 60 to 90 seconds. The results are not permanent, as peripheral nerves can regenerate, but most patients experience pain relief for 6 to 18 months, with the option of repeating the procedure as needed. Recovery is generally quick, with most patients resuming normal activities within a few days. RFA is particularly effective for patients with scoliosis who suffer from localized mechanical back pain without major nerve root compression or spinal instability. However, it is not typically useful for radiating leg pain or other neurologically complex symptoms. Some limitations include the potential for incomplete relief, nerve regeneration, and a rare risk of muscle weakness or neuropathic pain if unintended nerves are affected. Spinal cord stimulation, SCS, represents a more advanced, technology-driven intervention for patients with chronic, intractable scoliosis-related pain, especially when it has a neuropathic character, burning, tingling, shooting, or persists after spinal fusion surgery, known as failed back surgery syndrome. SCS involves the implantation of a small device, similar in concept to a pacemaker, that delivers mild electrical impulses to the spinal cord, typically in the epidural space. These impulses interfere with pain signal transmission between the spinal cord and the brain, effectively masking the pain with a tingling or non-painful sensation known as paresthesia. The goal is not to numb the spine, but to alter the way the brain perceives pain, thereby reducing the emotional and sensory impact of chronic discomfort. The process begins with a trial period. A temporary electrode is implanted under local anesthesia, and the patient uses an external stimulator for about a week to determine if pain relief is significant, ideally more than 50%. If the trial is successful, a permanent system is implanted, consisting of an internal pulse generator, usually placed in the buttock or abdomen, and leads positioned over the spinal cord. Modern SCS systems are rechargeable and can be adjusted remotely to tailor the stimulation to the patient's evolving needs. Newer devices offer burst stimulation, closer to natural nerve signaling, and high-frequency therapy, which may work without paresthesia. For scoliosis patients, SCS is especially beneficial for treating nerve-related pain following fusion surgery, disc degeneration with nerve compression, or central sensitization syndromes where the nervous system becomes overly reactive to stimuli. Both nerve ablation and SCS come with distinct advantages and drawbacks, and patient selection is critical for achieving successful outcomes. Nerve ablation is relatively low risk, cost-effective, and repeatable. It is best suited for patients with facet joint-mediated pain, often on the concave side of a spinal curve. However, it does not treat deeper structural pain or nerve root compression and is not curative. On the other hand, spinal cord stimulation offers hope to patients with chronic neuropathic pain who have exhausted other options. It can reduce reliance on opioids, improve sleep, and restore function. However, SCS is expensive, requires a surgical implant, and may involve complications such as infection, hardware migration, or equipment malfunction. The effectiveness of SCS can diminish over time, and not all patients are responsive. Additionally, the psychological component of chronic pain must be evaluated prior to implantation. Patients with untreated depression or anxiety often have poorer outcomes. In conclusion, nerve ablation and spinal cord stimulation are powerful tools in the multidisciplinary management of scoliosis pain. While neither corrects spinal curvature, both can interrupt pain pathways and help patients regain control of their lives. They serve different patient populations and pain profiles, ablation for focal mechanical joint pain, and SCS for widespread or neuropathic pain patterns. When combined with physical therapy, psychological support, and individualized pain management plans, these interventions can make a profound difference. Careful assessment, appropriate imaging, and diagnostic trials are essential to match the right technology to the right patient. As interventional pain techniques continue to evolve, scoliosis patients living with chronic pain have more options than ever before to achieve long-term relief and functional recovery.